Yes, ma'am, we are live now.
Okay. Good evening, everyone, and welcome to the 24th series of ISPAE ACES meeting. Today, we'll be discussing on bone disorders in children. May I request everyone to write questions in the chat box so that we can discuss at the end of each session. Without much delay, may I please invite our President of Indian Society of Pediatric and Adolescent Endocrinology, Dr. Ahila ma'am, to proceed further. Over to you, ma'am.
Good evening, friends. It's a pleasure to be here today amongst our esteemed faculty, Professor Zulf Mughal and Professor Rajesh Katgawar. And we have some wonderful presentations under the guidance of Dr. Akanksha Parikh and Dr. Ashima Tabas. And we are very thankful to Preeti Sharma and Ashwini for taking the pains to prepare a good presentation and help us widen our knowledge. Thank you so much and welcome to everyone. And we are deeply thankful to both Professor Mughal and Dr. Rajesh for their kind acceptance of for delivering the lecture today. Welcome to the program. Thank you so much. Thanks, Zalak, for all the efforts. Now, I would like to take the opportunity to introduce Dr. Akanksha Parikh, who is a pediatric endocrinologist at the Gokilaben Dhirubhai Ambani Hospital at Mumbai. She's a wonderful pediatric endocrinologist with a wide knowledge, and she will help the presenter through the case presentation, and we can have questions at the end of the session. Welcome, Dr. Akanksha.
Thank you, ma'am. Thank you so much for the kind introduction, and a quick thank you to the entire team of ISPAE ACES for providing me the opportunity to be here. So without further ado, the first session is a case presentation by Dr. Preeti Sharma. She is a fellow at AIIMS Jodhpur, and she will be presenting a case on rickets. Over to you, Dr. Preeti.
Good evening, ma'am. Today, I will be presenting an interesting case of rickets. My slides are visible, ma'am?
Yes, yes, they are.
And my voice is
You'll need to make it slideshow, though.
Yes, ma'am, sure.
Yes.
Okay. So I'm Dr. Preeti Sharma. I'm currently working as a fellow in pediatric endocrinology, AIIMS Jodhpur. I am presenting an interesting case of rickets under guidance of Dr. Akanksha Parikh. Starting with the history, a 2-year-old girl, child born out of non-consanguineous union presented to us with chief complaints of poor height and weight gain since 8 months of age, progressive limb deformity since 1 year of age, delayed motor milestones as she cannot walk or stand till now, and listlessness and irritability since last 6 months. She has a history of recurrent respiratory tract infections also since late infancy, none requiring admission, no history of recurrent fractures, no history of polyuria or polydipsia, no history of recurrent diarrhea or vomiting, no history of any abnormal body movements or anti-epileptic medication intake, no history of any hair, skin or nail abnormality. Antenatally, mother was a registered case and received folic acid, calcium and iron supplementation. Otherwise, antenatal period was uneventful. The child was a term-born baby of normal vaginal delivery with a birth weight of 2.8 kgs. She doesn't require any NICU admission postnatally. She was exclusively breastfed till 6 months of age and thereafter adequately weaned. She did not receive any vitamin D supplementation during her infancy period. Treatment-wise, she received conventional doses of calcium and vitamin D from multiple practitioners from last 1 year, but parents did not notice any clinical improvement. Development history, she can sit without support since 9 months of age, and crawling was present since 12 months of age, which was delayed for her age. And she is not able to stand or walk till now. Language and social milestones are normal for age. Family history-wise, she was the firstborn child of a non-consanguineous union, with no other family members affected with the similar complaints except her 15 months old younger brother, who also started developing limb deformities from 8 months of age and had delayed motor milestones with signs of rickets also. He is currently on our follow-up. Immunization was complete for each, and family belongs to the lower middle class according to modified Kuppuswamy scale. Now, coming to the examination, vitally she was stable except RR of 38 per minute, which was mild tachypnea, suggesting of mild tachypnea. Anthropometry wise, weight was 6.8 kg minus 4.82 standard deviation. Length was 68 centimeter minus 6.26 standard deviation. Head circumference was 45 centimeter minus 1.75 standard deviation. So child was severely wasted and severely stunted according to the WHO growth charts as shown in the chart also. On general examination, child was having frontal bossing, wide open anterior fontanelle, rhaketic rosary was present, kyphosis was present, Harrison sulcus, bilateral wrist widening was present, bowing of bilateral forearms and legs was present, and generalized hypotonia was also present. These are the clinical pictures showing the similar findings. The first picture is showing wrist widening. Second picture is showing the rhaketic rosary. Third picture is showing the pot belly. Fourth picture is showing the kyphosis. And the last two pictures are showing the limb deformities. Systemic examination wise, on respiratory examination, mild subcostal restrictions were present, but there was no intercostal retractions or any added sounds. Abdomen examination showed distended abdomen, but it was soft with no organomegaly, and rest systemic examination was unremarkable. Our clinical impression on the basis of history and examination was a 2-year-old girl with failure to thrive, isolated motor delay, with bony changes persisting despite vitamin D and calcium supplementation, with a similarly affected younger sibling suggestive of an inherited cause of non-nutritional rickets. On investigation, radiologically, bilateral hand X-ray was showing the widening, cupping, and splaying of the distal end of radius. And also there were history of multiple, there was not history, but this X-ray was showing multiple fractures in different stages of healing, and severe osteopenia is also visible. Similarly, the lower limb X-ray is also showing the cupping, splaying, and fraying in the distal end of femur and bowing of fibula. With the chest X-ray showing this wavy pattern because of the expansion of the anterior end of the ribs and costochondral junctions with mild interstitial infiltrates. On biochemical investigation, at 15 months of age on outside investigation, the child was having serum calcium of 8.2, that is low, serum phosphate of 3, that is also low, and alkaline phosphatase of 942, that is very high. And 25 hydroxy vitamin D was 95.2, that was sufficient, but no other investigation was available. At presentation to us at 2 years of age, child was having a low calcium of 7.75, low phosphate of 2.46, very high alkaline phosphatase of 4042, and in intact PTH of 958, that was also very high, and 25 hydroxy vitamin D of 723, that was in toxicity level. So based on these investigations, the child was classified as a calcipenic rickets because of very high IPTH and hypocalcemia and hypophosphatemia. So we decided to go for 125 dihydroxy vitamin D, which was 333 picomole per liter, which was in the higher normal range. Rest VBG doesn't show any acidosis. Serum creatinine was also normal and serum albumin was also normal. So our diagnosis came out to be non-nutritional rickets, likely VDDR. Our first possibility was non-allopathic VDDR type 2, but we cannot rule out the possibility of VDDR type 1 also based on the absence of ectodermal defects and alopecia. So we decided to go for the genetic analysis. On genetic analysis, the child was having homozygous mutation, frame shift type of mutation at gene CYP27B1 with the shown variant, and the findings were consistent with vitamin D dependent rickets type 1 with autosomal recessive inheritance pattern, and it was classified as pathogenic variant. So our final diagnosis came out to be VDDR type 1A. The treatment we started the child on was oral calcitriol 0.25 microgram BD, which was subsequently increased on follow-up based on the biochemical investigations on follow-up and the response of the child. Calcium was started at 50 mg per kg per day. Phosphate was started at 12 mg per kg per day. Although the parents were poorly compliant for the treatment on follow-up, so we did not have much increase in the weight or length on follow-up as shown in the WHO growth chart. On follow-up investigation also, there is not a definite pattern of increase in the serum calcium or phosphate after 1 month or 3 months. There was a slight decrease in intact PTH level at 644 after 3 months, and urine calcium creatinine ratio done at 3 months was 0.1. That is normal for the age. So because of the poor compliance, there was not a consistent improvement in the results of biochemistry. Child also had 3 consecutive episodes of pneumonia during follow-up, and after the during the third episode, she succumbed at the age of 2 years and 8 months. But the younger sibling is still on treatment and on her follow-up. Now some slides regarding the discussion. So approach to non-nutritional rickets. Whenever we suspect a refractory rickets, we should look at a phosphate first. So whenever there is a high phosphate, there will be a possibility of CKD, chronic kidney disease. Whether it is low, then there will be 2 possibilities, calcipenic or phosphopenic rickets. So under calcipenic rickets, there can be VDDR type 1, 2, 3 or distal RTA. Under phosphopenic rickets, there can be X-linked autosomal dominant or autosomal recessive hypophosphatemic rickets, hereditary hypophosphatemic rickets with hypercalciuria, Fanconi syndrome or Dent disease. This is a slide differentiating between VDDR and hypophosphatemic rickets. So the basic defect in the enzyme in VDDR type 1A is CYP27B1, which encodes for enzyme 1-alpha hydroxylase deficiency. In VDDR type 1B, there is CYP P2R1 enzyme defect, which is encoding for 25 hydroxylase deficiency. In VDDR type 2A and 2B, there is a impaired signaling of VDR receptor, and in hypophosphatemic rickets, there can be an excess of FGF23 due to mutation in FEX gene, or there can be a proximal RTA. Serum calcium will be low in VDDR, but it will be normal in hypophosphatemic rickets. Serum phosphate will be normal or low in VDDR, but it will be very low in hypophosphatemic rickets. ALP will be very high in VDDR, but it will be high on the higher side in hypophosphatemic rickets. 25 hydroxyvitamin D will be low in VDDR type 1B, but it will be normal in VDDR type 1A. So we can differentiate VDDR type 1A and B based on 25 hydroxyvitamin D levels. It will be normal in other 2 varieties. 125 dihydroxyvitamin D will be low or low normal in VDDR type 1B or low in VDDR type 1A, but it will be high in VDDR type 1, VDDR type 2. So it can be used to differentiate between VDDR 1 and 2, and hypophosphatemic rickets, it will be low. So maintenance dose of calcitriol required for the treatment of different types of calcipenic rickets will be in VDDR type 1, 0.3 to 2 microgram per day lifelong requirement will be there. In VDDR type 2, 5 to 60 microgram per day lifelong requirement will be there. In hypophosphatemic rickets, 20 to 30 nanogram per kg per day with oral phosphate of 20 to 60 mg per kg per day lifelong requirement will be there. Our follow-up goals for the therapy will be to maintain serum calcium in the low normal range, serum phosphate in the normal range, serum PTH in the high normal range, and periodic monitoring of urinary calcium and creatinine ratio to prevent nephrocalcinosis. And our target should be less than 4 mg per kg in a 24-hour sample. This is one of the study conducted in 2021 in the Turkey, in which they reviewed the literature and also reported 13 new cases to understand the genotype and phenotype correlation that exists in VDDR type 1A. So they found three most common mutations in CYP27B1 mutation, with one of this PF443, PFS24 mutation, frameshift mutation, which was also present in our index case. But they concluded that the variation in 125 hydroxyvitamin D could not be explained with genotype, as two of their subjects with the same mutation of PF443 was having normal 125 dihydroxyvitamin D, and the other was having a high level also. So they postulated that the findings suggest that 25 hydroxyvitamin D3 could be converted to 125 dihydroxyvitamin D3 by a non-CYP27B1 enzyme or other enzymatic pathways involved in vitamin D metabolism or degradation. So this is one of the supportive evidence we could collect. The take-home messages would be that early identification and treatment of a non-nutritional ricket is essential to reduce the risk of associated complications. Biochemistry should be supplemented with the genetic analysis wherever possible for ensuring the appropriate therapeutic regimen, and treatment compliance and long-term follow-up is necessary for better outcomes. Thank you.
Akansha ma'am, you're mute.
I apologize. So thank you, Dr. Preeti, for a detailed and yet a concise presentation. This case, illustrates the challenges which one practically faces, not just in the diagnosis of non-nutritional rickets, but also in the treatment of such cases. And often we do see that the clinical picture and the biochemistry can overlap between two similar conditions, but it's important to differentiate between the two because the therapies that one gives for both can be very, very different. Before we address the questions in the chat box, I just have a question. Would you, going back, would you have considered, starting at a higher dose of calcitriol and maybe hiking it up further and sooner, seeing that, there's been no serial change in the alkaline phosphatase level and the phosphate level, which continue to remain low?
Ma'am, we could have started definitely with a higher dose, but the issue which we are facing was that the child was having a very high level of toxicity level of 25 hydroxyvitamin D, and the child's consistency was also not, he was very poorly compliant for the medicines. Have it been that the child is very consistent with the medication, still we are getting the similar biochemistry on follow-up, then definitely we would think to rapidly hike, or we would like to start with a higher dose initially.
Yes, so maybe another clue towards VDDR1 in this child could be that although the 25 hydroxy was in a very highly toxic range, but in comparison to that, the 125 dihydroxy level was just on the upper normal limit. We have a question in the chat box that did you do anything for the vitamin D toxicity? Also, which calcium preparations do you prefer? What did you give to this child?
We can do a hydration. We can first see for the hydration status, and we can hydrate the patient. And secondly, we can go for the steroids for toxicity signs. But the child was not having any signs of toxicity currently as a clinical feature. So we decided to just continue and monitor with the therapy.
Okay. And the second part of the question is, which calcium preparations do you prefer? What did you give to this child?
Calcium XP, we started with Calcium XP, ma'am.
Okay. So just again, another question that when you evaluated the sibling, did the sibling also have a similar, high 125 dihydroxyvitamin D, which could fit in the postulation that there could be a external mechanism of conversion of 25 hydroxy to 125?
Ma'am, we were not able to do 125 dihydroxy in the younger sibling because of the financial status of the patient, as we have to send it outside. It is not available in our institute. So they denied for that. But seeing the picture of the child and the similar presentation as her sister, so we started him on the calcitriol with a higher dose. And now the child is doing fine. His calcium levels are also in a normal range, and ALP and IPTH are also falling.
Right. And just a last question that, sometimes we say that the 25-hydroxy vitamin D as an assay, you can have other metabolites interfering with it, the vitamin D2 and the 24-25. So is that similar for the 125 dihydroxy vitamin D as well?
125 dihydroxy vitamin D, ma'am, I'm not aware of any metabolite interfering with that.
Okay. Would anyone from the faculty present like to ask any questions to Dr. Preeti?
Yes, I think, yes, sir.
Sir, Zulf Mughal, sir, would you have some comments?
Hi, Dr. Sharma. Thank you very much for excellent presentation. I have to say that I was quite intrigued to find raised 125 dihydroxy vitamin D levels, because I've seen quite a few of patients with vitamin D dependent rickets type 1A, but never have they had high levels of 125. So this is something new. But that being the case, I would have actually considered treating this patient as if she had vitamin D dependent rickets type 2, because the main purpose of healing the rickets is to provide enough calcium, suppress the PTH, which then reduces the urinary phosphate loss, which then prevents the apoptosis, which sort of causes the apoptosis of terminally differentiated chondrocytes and in the growth plate and heals the rickets. So I would have considered, when you are not winning with the treatment, to perhaps put an intravenous long line in and consider giving calcium infusions like we do with vitamin D dependent rickets type 2. Did you ever consider that?
No, sir, we didn't consider that. We didn't give IV calcium supplementation, because in between the child was also having sometimes a normal calcium, and then he stops taking treatment, and then subsequently the calcium falls. So there was some improvement initially, but that's why we didn't opt for the IV calcium. And child was not having any tetany kind of episodes also. So we decided to continue.
So the key is not to it's not to focus on the serum calcium, because these patients have hungry bones, and the real aim is to try and fill these hungry bones with enough calcium, whether you give it orally or whether you give it intravenously, and the aim is to suppress the PTH. I think you actually mentioned, which I was a bit surprised, that you want to keep the PTH at higher end of the normal range, which is a little bit surprising, because the whole idea is to suppress the PTH so that you can reduce the urinary phosphate loss, normalize serum phosphate, which then in turn causes healing of the rickets.
Yes, sir. Actually, it was mentioned in some of the texts which I concluded that the PTH should be kept in the normal range, but in the higher normal range, so that it will help in the phosphate urea to prevent the phosphate urea and help the ossification of the chondrocytes. But why it should be kept in a higher IPTH range, I am not clear.
So the only time when we tend to do that is in renal rickets, which of course is a totally different thing. So then there, if you suppress the PTH completely, you get the adynamic bone disease, which is what you don't want. But thank you very much. That was an excellent presentation.
Thank you, sir.
Thank you. Zulf, sir, if I could just ask you a question related to that. We spoke about giving IV calcium at a large dose. So what in your practice would be the maximum oral calcium dose that you would give?
Well, it's interesting. So in my travels, I've been to sort of resource poor countries, for example, in Palestine, this is a very common condition, and the resources are so poor that what they tend to do there is to put a nasogastric tube down and give a lot of calcium very frequently down the nasogastric tube, because calcium salts are so unpalatable. To actually expect these poor kids to take it very frequently is really a big ask. So, but if they can give it if they can't give it intravenously, if you can give it orally, then they can actually get quite a bit, suppress the PTH and start getting some healing of the rickets. So, and that's something worth considering, especially as it was mentioned that this particular family did not come from a very well-to-do family, and they probably would struggle with having a long line in and not forgetting the risks of infection as well when you have a long line which is not kept clean, etc. So as to the dose, I don't know the precise dose, but basically you give enough to suppress the PTH. That's the whole goal. Basically, these kids have very hungry bones, and they're just craving for calcium.
And so if I may just ask one last question, that in your experience, does, we know that we've read that alpha calcidol works the same as calcitriol. Would you prefer one over the other?
I don't think there's much difference. The only advantage of alpha calcidol, which is what we tend to use, is that you can generally get away by giving it once a day, whereas with calcitriol, sometimes you have to give it twice a day. So it's an adherence issue. It may improve the compliance. The only situation I would not use alpha calcidol is when I'm concerned about liver disease, because as you know, it's in the liver that one alpha gets converted into 125. So in patients who have bone disease in the context of underlying liver problems, then I would go for calcitriol.
Yes, because sometimes alpha calcidol in our setting can turn out to be as a cheaper alternative to the calcitriol. So that sometimes is something we resort to. I think we don't have any more questions in the chat box. Ahila ma'am, can we go to the next session?
Yes, please. Thank you.
Yes, thank you, ma'am. So thank you, Dr. Preeti, for the wonderful case presentation. Thank you, sir, for your inputs as well. We'll go on to our next session, which is a talk by none other than Professor Zulf Mughal, sir. He's going to be talking to us on novel therapies in metabolic bone diseases. Sir needs no introduction, but he is a consultant in the pediatric and bone diseases at the Royal Manchester Children's Hospital. He has an extensive experience in the management of childhood bone and mineral disorders. Sir has published more than 185 peer-reviewed scientific papers, including book chapters. And Sir was awarded the Charles Slaminder Award at the 7th International Conference on Children's Bone Health in Salzburg, Austria in 2015, and in recognition of his contribution to pediatric bone research. And recently, he's also been awarded the Dent Award by the Bone Research Society. Thank you so much, sir. It's an absolute privilege to have you here, and we're eagerly awaiting your talk. Thank you.
Thank you very much for that kind introduction. Let me see if I can share my slides. Good evening, everyone. And really, I'm very, very grateful to the Indian Society for Pediatric and Adolescent Endocrinology for inviting me to participate in this meeting. So I'm going to talk about novel therapies in metabolic bone disease. The whole landscape of treatments for children with bone disorders has changed since we have been able to understand what the underlying genetic mechanisms are, but more important, what are the downstream pathways which are affected by the pathogenic variants. And this has allowed clever scientists to sort of work out ways of targeting the abnormal pathways. And so this has spurred new treatments which have starting to emerge. So I'm going to discuss some of those which have already been licensed and are being used, at least in the West, and some which are in the pipeline. So these are my disclosures, and I've focused on the disclosures mainly from the pharmaceutical companies, because in the United Kingdom, the National Health Service, which is where we work in hospitals, has a very active collaboration with pharma companies, whereby we sort of undertake clinical trials in children with rare bone disorders or other disorders. So I'm going to, over the next sort of 25 minutes or so, discuss a number of different conditions. The first one is autosomal dominant hypocalcemia type 1, and then X-linked hypophosphatemia, or what was called X-linked hypophosphatemic rickets, a very rare disorder of bone mineralization called hypophosphatasia, and then, of course, the commonest bone disorder, which we all probably deal with, associated with increased fragility fractures, which is osteogenesis imperfecta. Emphasize the need for early diagnosis in the era of genomics, and the importance of multidisciplinary care to actually optimize the support that we give to these children. It is more than just giving them treatment. So let's start with autosomal dominant hypocalcemia type 1. So this is really just a recap of control of calcium homeostasis. And the key, what I would like to focus is on this CASR, which stands for calcium sensing receptor, which is found ubiquitously, but the two main organs where it's heavily expressed is in the parathyroid glands and in the kidney. The ligand for the calcium sensing receptor is ionized calcium, and to some extent also magnesium, which are the two main ligands. So when the ionized calcium starts to fall, this then causes calcium sensing receptors to act on the parathyroid glands and release or increase the production of the parathyroid hormone, which then has a myriads of effects on the bone, on the kidney, and indirectly on the gut. So as you know, in the bone, it will act through the PTH1R receptor and mobilize the skeletal calcium stores in the hope of restoring the low calcium. In the kidney, it will cause increased conversion of 25-hydroxy vitamin D into the active form of vitamin D, which is 1,25-dihydroxy vitamin D, which in turn acts on the gastrointestinal tract and enhances the gastrointestinal calcium absorption. And in the kidney, it causes increased reabsorption of filtered calcium, so thereby reducing the calcium that is lost in the urine. And all these three mechanisms help to restore the calcium in the plasma, which, as you know, is crucially important for myriads of effects ranging from blood clotting to normal cardiac action, etc. And the high calcium, of course, has the opposite effect by suppressing the activity of the calcium sensing receptor. So this is a crucially important sort of regulator of calcium homeostasis. Now, if you have an activating pathogenic variant in the calcium sensing receptor, it alters the sensitivity of the receptor to calcium, thereby displacing the relationship between ionized calcium and PTH from the wild type. It displaces it to the left. And in the kidney as well, you sort of see the very similar things. The net effect of this is that the parathyroid hormones become less sensitive for the prevailing level of ionized calcium. So you actually get effectively hypoparathyroidism-like situation. The serum calcium goes down, and you have paradoxically increased urinary calcium excretion because this is expressed in the kidneys as well. And of course, the symptoms of low calcium, as we all know, are tetany, seizures, muscle cramps, and the effects of increased loss of urinary calcium is nephrocalcinosis, nephrolithiasis, and end-stage renal failure. So this is taken from a paper which looked at about 300 subjects with ADH1, and you can see that really large proportion of them were hypocalcemic. Some were symptomatic, some were asymptomatic, but many had sort of moderate to severe symptoms of hypocalcemia. So there's a heterogeneous sort of presentation. The same goes with hypercalciuria, and the low PTH again sort of fluctuated depending on, I suppose, the mutations that you had. And of course, the effect of the PTH on the kidneys, very similar to FGF23, which I'll be discussing shortly, is to actually cause increased urinary phosphate loss, so they get hyperphosphatemia. So the treatment of this condition, as you know, is to basically give activated forms of vitamin D in form of calcitriol or alpha-calcidol and calcium. The problem with that is that it helps to normalize serum calcium and thereby reduce the symptoms associated with hypocalcemia. But these patients are already have increased urinary calcium excretion. So it exacerbates that urinary calcium excretion and thereby worsens the risk of developing nephrocalcinosis, nephrolithiasis, and stage renal failure. So people have been wondering, how can we treat this rather complex disorder? So one approach is to give subcutaneous recombinant parathyroid hormone 1-34 infusions. And this is a paper which was published in New England Journal of Medicine by my colleagues from London, where they describe 6 subjects who were given these infusions, and it helped to normalize their serum calcium. It reduced their levels of seizures that they suffered from the pre-infusion era to the post-infusion era. It also reduced the number of days of hospitalization associated with their symptoms of hypocalcemia, especially the seizures. What is also very interesting is that the urine calcium to creatinine ratio, which is taken as a measure of urinary calcium excretion, actually went down in all the subjects. So these are individual subjects. These are their pre-treatment urinary calcium to creatinine ratio when they were taking oral calcium with activated forms of vitamin D, and which was then stopped, and then they were put on subcutaneous parathyroid hormone infusions using the pumps very similar to those used to treat diabetic patients, type 1 diabetic patients, and you can see that there was a significant fall in urinary calcium excretion. So this treatment actually helped to normalize serum calcium levels. At the same time, it helped to reduce urinary calcium losses. The problem is it's a very cumbersome treatment. The 1-34 parathyroid hormone is not licensed for use in children. And as you know, in preclinical studies in mice, it was associated with increased risk of bone cancers. So there is always a slight concern about using this. Having said that, we also use this in selected number of patients in our center. So what's the alternative? Well, the alternative is to use the calcilytic drugs. So like we have the calcimimetic drugs like cinacalcet, and there are also calcilytic drugs which can be given orally. And one such calcilytic drug is encalceret, which is a negative modulator of calcium sensing receptor. So basically it sort of blocks it sort of nullifies the effect of the activating mutation on the sensitivity of this receptor. So by sort of decreasing the sensitivity of the calcium sensing receptor, this drug basically pushes this relationship between PTH and calcium to the right, and bringing it to similar to what you see in the wild type or in healthy individuals. And the same effect occurs in the kidneys. So Rachel Gaffney and colleagues at the National Institutes of Health in the United States have done a phase 2 open label dose ranging study in adults. I mean, the aim is to sort of, first of all, establish its safety and also to find the optimum dose and the frequency of administration. I won't go into the details, but I think this graph shows very nicely that the use of this treatment helped to normalize the serum calcium, the shaded area being the normal range for serum calcium. At the same time, the urinary calcium excretion, which was measured as 24-hour excretion in these adults, sort of rapidly decreased. So basically, given twice daily, this treatment normalized blood calcium levels and urine calcium excretion, and the treatment was very well tolerated with no serious adverse effects. And so with that, our center, along with other centers in the world, will be starting phase 3 trial in children in the near future. So I think this is really very exciting, because this helps to, at fundamental levels, in normalizing the abnormal relationship between calcium and parathyroid hormone arising from the variants in the calcium sensing receptor. I'm going to switch gears and now move to X-linked hypophosphatemia. As you know, this is the commonest genetic form of rickets, with the prevalence which is quoted to be between 1 in 20,000 to 1 in 60,000. And typically these children present with short stature, with disproportionate short stature, I should say, deformities, usually genivarum, bow-leggedness of their lower limbs. Many of them have craniosynostosis. They have delayed motor development or degree of myopathy. They tire very easily. They are not able to do the physical activities just like their peers. And they have significant dental problems, because the whole structure of the dentine is very abnormal. So they get multiple dental abscesses, and they suffer from pain, though younger children find it very difficult to differentiate between pain and tiredness. As these individuals get older, they develop osteomyelasic bone disease, and the burden of disease continues to get worse in adults, because now they're developing paraspinal ossifications, spinal stenosis, as well as enthesopathies, or ossification of the insertion of the tendons at the bone and the ligaments, leading to stiffness. Hearing loss is again a very common feature. And so it's a chronic, lifelong disabling condition. And it arises from a mutation in a gene called FAX, which stands for phosphate regulating gene with homologous to endopeptidases on the X chromosome, which is a bit of a mouthful, but the mutations in the predominantly the osteocytes and to some extent osteoblasts lead to increased expression of fibroblast growth factor 23, or FGF23, which is normally cleaved. So it is produced but normally cleaved. But when you have mutated FAX, then you have high levels of FGF23, which acts on the kidney, and acting on the sodium-dependent phosphate transporter 2A and 2C, causing them to be downregulated. And this, therefore, prevents the reabsorption of the filtered phosphate, causing increased urinary phosphate loss. At the same time, the high FGF23 upregulates the the CYP24A1, which is responsible for breakdown of 125 and 25. And at the same time, it downregulates CYP27B1, about which we heard in the previous talk, which leads to reduced conversion of 25-hydroxyvitamin D into 125. The net effect is that you have less 125. This then leads to reduced gastrointestinal absorption of both calcium and phosphate. So with increased urinary losses of phosphate, reduced gastrointestinal absorption of phosphate, you have chronic hypophosphatemia, which then is the really fundamental to the pathogenesis of rickets, because rickets is a disease of impaired mineralization of the growth plate and the osteoid. And in the growth plate, you get sort of progressive differentiation of the chondrocytes, which also get bigger, and they need to undergo apoptosis to trigger the mineralization, and you need normal phosphate levels. If your phosphate level is chronically low, you will have impaired apoptosis, and this will lead to failure of mineralization, which will lead to the classical radiological appearance of the widening, cupping, and fraying of the metaphyses, as you can see here, and of course the classical geniovarum. But as I mentioned previously, there are many non-skeletal manifestations of this condition as well. The conventional treatment for the last 30 years or so has been to give neutral phosphate in the doses between 40 to 60 milligrams. No evidence base for this. It's just plucked from the air, I think, given about 5 to 6 times a day. And or calcitriol or alpha calcidol once or twice a day. And the goal of the treatment is to heal the rickets, prevent deformities, and improve the mineralization of the teeth and improve the myopathy. So you monitor the alkaline phosphatase and look at the healing of the rickets by radiographs. At the same time, you need to keep an eye on the PTH, because if you're giving industrial doses of phosphate, which we are doing to these patients, the absorption in the gut is not that much impaired. And so when this bulk of phosphate is absorbed, it causes a transient fall in ionized calcium, which triggers PTH response. So in order to replace the low 125 and also to suppress the high PTH, which can arise and further worsen the disease, you need to keep a very close eye on the PTH. And monitor for hypercalciuria. And so this is the phosphate Sandoz tablets that we use, which are dispersible, and then either calcitriol or alpha calcidol drops. This treatment is not easy. Phosphate salts taste absolutely foul. They cause nausea, they cause tummy pains, they cause diarrhea. And we expect these poor kids to take this for 5 to 6 times a day, which is a big ask. It does not persistently normalize the phosphate. So when you give it, it will transiently cause normal phosphate. And then as soon as it hits the kidneys, it gets peed out. So the adherence tends to be very poor, especially amongst adolescents. Secondary hyperparathyroidism, for the reasons I mentioned, is an ever-present problem. And if you don't keep an eye on that, it may lead to tertiary hyperparathyroidism. Half of our patients, in spite of meticulous monitoring, have mild degree of nephrocalcinosis. And with the best will in the world, you're only partially healing the rickets. So there is always a need for surgery, which these days we sort of do this, start with guided growth treatment with epihemiphysiodiasis, and only do the final corrective surgery when the growth is finished, which will require very complex surgery. The other paradoxical thing is that this treatment actually leads to higher FGF23 levels, which then further sort of worsen the whole thing. So so it's a very unsatisfactory treatment. So burizumab is a monoclonal antibody to FGF23, which has been shown in preclinical studies to normalize the abnormal physiology and rescue the bone and the muscle phenotype in this condition. So basically, it binds to the high circulating FGF23 and thereby improves the absorption of phosphate into the gut by preventing the urinary phosphate losses and also improving the 125 levels and in the gut absorption of phosphate and calcium. So there have been 3 pediatric trials, and we were involved in 2 of these trials. I'm just going to focus selectively on the results of the phase 3 trial, which was comparing children on conventional treatment with those receiving beruzimab. And you can see the TMP-GFR. This is looking at the tubular reabsorption of phosphate expressed to GFR. And as compared with those on conventional treatment, there was a rapid increase in reabsorption of phosphate, which translated into rapid increases in plasma phosphate, which remained persistently high as opposed to those on conventional treatment where it remained low. And there was using the Ricketts severity scoring system. At the start, in the 2 groups, the scores were very similar, but within 40 weeks and by 64 weeks at both those endpoints, the time endpoints, there was a significant improvement healing of the rickets and a significant decrease in alkaline phosphatase activity in those who received beruzimab. The 6-minute walk test, which is an looking at the muscle function and endurance things, also improved. There was a slight but significant improvement in height, which really, if you want to eke out height in these patients, you need to start them very early. And this is one of our patients who, at the age of 2 years, was started on beruzimab. You can see abnormal mechanical access, and within about 2 years of treatment, you can see completely restored mechanical access without any surgery, with healing of the rickets. Whereas the older brother also had the same things, had 10 years of conventional treatment, was treated on beruzimab, significant improvement in his muscle function. He started playing rugby and all sorts of games and started injuring himself for the first time. But you can see that we did not correct his deformities, so he still needed complex corrective surgery at the end of his growth. So beruzimab normalized serum phosphate, TMP-GFR 125 alkaline phosphatase. It healed rickets in osteomalacia, improved the linear growth, improved muscle functions in adults, studies which have not shown. It also reduced the fractures and pseudofractures and improved pain scores. And there are really very few adverse effects, which are really mild to moderate injection site reactions. And in the UK, every child who has PRO and FAX mutation now is eligible for this treatment. Let's switch to hyperphosphatasia, which is a disorder of abnormal mineralization. So again, this comes to the role of phosphate and alkaline phosphatase. So ATP gets broken down by this enzyme ENPP1 into inorganic pyrophosphate, which is a potent inhibitor of mineralization. So it inhibits the mineralization of calcium and phosphate in the hydroxyapatite and in the teeth. The alkaline phosphatase activity is to suppress this PPI and allow normal hydroxyapatite formation, and therefore allow bone and dental mineralization. If you have mutations in the genes encoding for alkaline phosphatase resulting in low alkaline phosphatase levels, you get higher inorganic pyrophosphate levels, which then lead to impairment of mineralization. And this causes hyperphosphatasia, which is a very heterogeneous condition, from perinatal severe, usually fatal, to benign perinatal, where you have changes in the perinatal period, but they improve during last part of pregnancy or after birth, infantile HPP, which presents in the first 6 months of life, juvenile HPP from about 6 months to 18 years, and some only have odontohypophosphatasia, which affects the teeth, and it may present for the first time in adults. The treatment up to now has been entirely supportive with physiotherapy, occupational therapy, pain relief. They all have hypercalcemia because the calcium is just not getting into their bones, and they therefore have symptoms of hypercalcemia. So you need to manage them with hydration, furosemide, and dietary calcium restriction. Because you're not getting vitamin B6 into the brain, which needs to be dephosphorylated by the alkaline phosphatase, get into the brain where it's rephosphorylated for production of the neurotransmitters. You get these severe seizures in these patients. You can have raised intracranial pressure, craniosynostosis, fractures. The main sort of change or the game changer has been the recombinant bone-targeted treatment with aspartate alpha, which consists of dimers of alkaline phosphatase bound to IgG fragment, which is for purification. And the clever bit is the decasparte motif here, which allows it to bind to the hydroxyapatite crystals as shown here in the micro radiographs. So in the past, people have given alkaline phosphatase taken from the placenta or from patients with Paget's disease to patients with hyperphosphatase. It did not work because you need to have a bone-seeking mechanism, which is what is a clever bit in this engineered molecule. So the trials with this showed that with the severe form of hyperphosphatasia, it not only improved mineralization, it also compared with the historical natural history study where there's sort of more than 50% death by 6 months, it improved the survival significance. I'm running out of time, so I'm just going to skip to osteogenesis imperfecta and just go to what is going to be the new treatment. So the current treatment, as you know, is basically supportive treatment and use of bisphosphonates, which basically reduce the increased bone turnover by shutting down the osteoclasts. The clever thing which has emerged is by looking at these two conditions called related conditions known as sclerostosis or von Buckham disease, which are caused by suppression of the sclerostin gene. Sclerostin is produced by the osteocytes, and the normal function of sclerostin is to work through the Wnt signaling pathway, bind to LRP5 and LRP6, and reduce the bone formation by suppressing the osteoblasts, at the same time increase the bone resorption. And so if you have inactivating mutations in these SOS genes, you have very thick skulls, very strong bones. You can see that the weight of one skull is heavier than 3 skulls here with a patient with the von Buchan's skull. So sclerostin, basically, if you block the sclerostin, you will cause increased bone formation and at the same time reduce bone resorption, whereas bisphosphonates only target shut down the bone resorption by causing apoptosis of terminally differentiated chondrocytes. So this was the ASTEROID study in adults, which was really looking at the dose escalation study, looking at markers of bone formation biochemically and bone resorption, at the same time looking at the DEXA and a very special technique known as high-resolution peripheral quantitative computer tomography, which allows you to look at bone strength and trabeculae in more details. And after 3 doses of this, you can see improvement in bone formation markers with P1NP, bone-specific alkaline phosphatase, P1CP in osteocalcin going up, at the same time CTX, which is a marker of bone resorption, going down. This translated into improvements in bone strength parameters measured by HRPQ-CT, improvement in lumbar spine aerial bone density measured by DEXA, and the fracture rates sort of were going down, but adults with OI don't get as many fractures as children, so it was inadequately powered. But there are 2 trials starting using 2 different anti-sclerostin antibodies, and we are going to be participating in both those trials. So there is a real hope that for the first time we'll have both an anabolic agent as well as something which is going to shut down bone. And in preclinical studies, it has been found to improve the bone strength of mouse models of OI. So one of the challenges is that if you're going to have these expensive drugs, you need to make the diagnosis early. So in the UK, we are starting with sort of the whole exome sequencing of all newborn babies to try and identify those who have rare diseases, such as rare bone problems, so that we can monitor them carefully and give them early access to these wonderful new treatments. But at the same time, you really need a very good pediatric metabolic bone team. And so this is a very outdated picture of our bone team. We have got a much bigger team now. and some of the faces have gone and some have joined. But we are all focused in a holistic way at looking at bonds, and the key people are our therapists, who support the children with strengthening exercises, with dealing with their daily living needs, and supporting them. But at the same time, you need your orthopedic surgeons, neurosurgeons, dentists, radiologists, audiologists, clinical geneticists. And of course, these patients are like your own children. So having looked after them for almost 20 years, sometimes 18 years, you need to transition them, hand them to expert adult colleagues. And so we do sort of regular transition clinics with our adult colleagues. And I think it's having this teamwork which actually makes all the difference. So I'm sorry that I've exceeded my time, but it's a bit of a khichdi of bone disorders that I've given you. Thank you very much.
Thank you, sir, for that extremely illuminating and lucid presentation. You've answered a few questions for us, but you've also stimulated many, many more. And on that note, sir, if I may ask you, when it comes to Birosumab, what happens to the PTH when patients are on Birosumab?
Yeah, very interesting question. So initially it didn't change, but some patients, after sort of they've been on treatment, a few patients actually are starting to get rise in PTH, which is a bit worrying because that is going to nullify the effect of this agent. And in one patient, we actually developed a parathyroid adenoma, and that patient's had an adenoma removed. And there's another patient in Netherlands. So my colleague, Dr. Padadella, is going to team up with the colleague in Netherlands to write up those cases. But these are rare. Majority of them are basically fine. The important thing is to make sure that they're vitamin D replete. In the UK, we don't have, I mean, this month has been very unusual. We've been having very nice summer so far, but normally it's very cloudy, very dull. It rains all the time. There is no sunshine. So everybody's vitamin D deficient. So if you become vitamin D deficient, your PTH will rise and you will get, it will nullify the effect of Birosumab. So you must always give them vitamin D supplements, keep their 25 OHD above 50 nanomoles per liter, and give them adequate calcium, or make sure that you're taking a good dietary history.
Thank you, sir. Ma'am, do we have time for a few more questions?
Two or three questions.
Okay.
I apologize for taking up too much time.
No. So the other question is that when we are starting children on Birosumab therapy, how do we talk about response to the therapy? Do all children respond equally? And also, do you find that with time the response reduces, you need to hike up the dose?
So we've been treating, because we were the trial center, we've been treating now for 7.5 years, and the response is very dramatic. So the low phosphate normalizes, the alkaline phosphatase comes down, and the rickets heals. But unfortunately, the deformities will only correct in younger children. So as I showed in one example, if you start over the age of 5 or 6 years, they will still need the help of our friendly orthopedic surgeons to correct the deformities. But the biochemical response is very rapid, very rapid.
Ma'am, you're on mute, I think.
Thank you so much, Professor Mughal. Thank you for that wonderful lecture. I think, as Akanksha had mentioned, stimulated a lot more questions, and I'm sure our pediatric endocrinologists would like to write to you, and I hope we don't disturb you too much. Thank you so much. And thanks for being kind enough to come on and expose us to all these new agents that are available for treating bone disorders in children, because a lot of our families feel it is, I mean, they're really sad that they don't have anything to offer to their children, and I hope this comes to India also soon. Thank you so much for raising our awareness.
Thank you very much.
Thank you, Akanksha, for leading that session well. And we move on to the next part of the program. May I invite Professor Ashima Tabas, who's an associate professor of pediatrics and pediatric endocrinology at Maulana Azad Medical College. The program will be carried forward by Professor Ashima Tabas. Ashima, the floor is yours.
Thank you, ma'am. And thank you, the ACES team, for putting up this wonderful compilation. So without taking much time, we start with the next case, for which we have a very nice presentation from Dr. Ashwini, from a DNB fellow from Kanchi Kampoti Children's Trust, Chennai. So over to you, Ashwini, and then we can, I think, discuss later.
Thank you, ma'am. Are my slides visible, ma'am?
Yeah, please make it to slide share.
Yeah.
Screen, yeah. Go.
Is a thyroid adenoma, which presented as vaginuvalgum. So we have a 10-year-old male child who was first born to non-consanguineous parents. He's a developmentally normal child with no significant illness in the past. It was initially seen in the orthopedic OPD in view of progressive angular deformity of the knee, which caused him difficulty in walking. It was initially noticed 2 years back by the parents, causing a slowly progressive medial angulation at the knee joint. It was noticed in both the knees, with left knee being more than the right, and it did not cause any pain or any fall during walking. There was no history of any previous trauma, pain, or swelling of the joints. There was no history of any recurrent abdominal pain or malabsorption. There was no history of pallor, jaundice, or abdominal distension. No history of any other bony abnormality or dental issues. And he was not on any prolonged drugs, or no history of polyuria, polydipsia. There was no seizures. Diet-wise, his diet was adequate in micro and macronutrients. There was no past history of being treated for any medical conditions or any surgeries in the past, and no family history of short stature or skeletal dysplasias. So for the above condition, he was initially evaluated and a year back, and it was found that his vitamin D levels were low, less than 8, and ALP was high in 2000s, and his calcium was high, whereas his phosphorus was on the lower side, 3.2. So he was initially being treated with vitamin D supplements. This was his initial X-ray done at first visit, where the knee joint did not show any typical rickets changes. There were only minor irregularities seen at the end of the ankle joints. Otherwise, there were no typical rickets changes that were seen. And he was started on vitamin D supplements, and he was followed up 2 months later. And the labs done 2 months later showed an increase in vitamin D levels up to 42, and there was a minor drop in ALP levels. Although the calcium levels further increased and the phosphorus did not improve. Following this visit, the child was lost to follow up, and the parents did not turn back for a year. So after a year, they got back with the increase in the deformity, and there was not much of improvement symptomatically. So his labs were repeated, at which time his vitamin D was again in the insufficient range, and his ALP was again in thousands. It was elevated. His serum calcium was in the upper range of normal, 10.5, and phosphorus was still low. The corrective procedures for genu valgum was done by orthopedician fixation at this point, and he was again discharged on vitamin D supplements in the supplementary dosage of 400 international units per month, calcium of 500 mg OD. So on follow-up later on, it was noticed that he did not have any much clinical or radiological improvement even after the surgery and with vitamin D supplements. So the vitamin D persisted to be low with a high ALP. The one clinching point was the phosphorus being low. So this time an ionized calcium was done. It was 1.6. And in between this, parents had also tablets and vitamin D. So this calcium level, the high calcium levels were not attributed to heterogeneically high calcium. And the points that were against nutritional rickets is that he was a wealthy child, even though the initial supplements were adequate with a good compliance. And there were no typical rickets changes initially, both clinically and radiologically. And his labs were persistently showing a high elevated calcium level, high ALP, and a marginal low phosphate. A complete workup further. Referral was made, and when we saw the child on examination, he was well nourished, he was hydrated, there were no features of dysmorphic facies, no alopecia, there was no pallor, icterus, clubbing, or edema. His oral cavity and dentition appeared normal. There was bilateral genovalgum was noticed, left being more than right, and flat foot was present bilaterally. There was no other bony deformities that were seen, although surgical scar was present in bilateral knee. No signs of was seen, no features of any other vitamin deficiencies, and his spine
Sorry,
was normal.
Ashwini. Can
Yes,
you
ma'am.
just switch off your camera so that your audio is better? There is a slight break in the presentation. Please continue, please. Thank you. Sorry.
Yes. And his intermalleolar distance was noted to be 18.5 centimeter. And his vitals were stable. There were no irregular rhythm or tachycardia suggestive of for hypercalcemia. And BP was in the 50th centile. There was no evidence of hypertension. His anthropometry was in height was between 50th to 75th centile, and weight was also between the 50th to 75th centile. His target MPH was he was within the centiles. BMI being 17.5. Stanner stage indicates prepubertal. Systemic examination was otherwise normal with cardiovascular and respiratory system having additional findings. Abdomen was soft. There was no organomegaly. Cranial CNS was high normal, and his were also normal. So on summarizing, we have a 10-year-old child with slowly progressive genovalgum, for which he was operated with no other features of systemic disease. And there was a poor response to vitamin D and calcium therapy with underlying hypercalcemia and metabolic bone. So the causes of hypercalcemia that can be thought of in this child would be PTH dependent or independent. PTH dependent would be primary hyperparathyroidism, familial hypocalciuric hypercalcemia, or a tertiary hyperparathyroidism due to CKD. Whereas the PTH independent causes would be due to drugs or drugs like thiazides or vitamin D intoxication, other endocrinopathies like hyperthyroidism, Addison's, FEO, etc., and prolonged immobilization, any congenital syndromes like Williams syndrome, or any malignancies like lymphomas or granulomatous disease that can cause hypercalcemia. So, as per definition, his calcium levels were more than 10.7 with an ionized calcium of more than 1.38. So, the next step would be to measure an intact PTH. So in case where we measure a PTH, if there is a hypercalcemia with elevated PTH, it would suggest a probable primary hyperthyroidism. But on the background of hypercalcemia with a low PTH, it would suggest other non-PTH mediated causes of hypercalcemia. And with hypercalcemia with the borderline PTH, we'll have to differentiate between primary hyperparathyroidism versus familial hypocalciuric hypercalciuria. So at this stage, our next step was to do a PTH. So the PTH was very high in 1112 picograms per ml. So at this point, the probable differential primary hyperparathyroidism due to adenoma, hyperplasia, or Men's syndrome, and familial hypocalciuric hypercalcemia. The investigations, like he had a normal hemoglobin and blood count, his function tests were normal, and his gas was normal. And ECG did not show any changes suggestive of hypercalcemia. So the next step would be to do a 24-hour urinary calcium excretion to differentiate between primary hyperparathyroidism and hypocalciuria. So if it is the normal calcium excretion would be anything between less than 200 mg per day and of 0.01 to 0.02. In cases where it is normal or low, there might be an associated vitamin D deficiency that can mask. So in those cases, the vitamin D deficiency has to be corrected before proceeding with urinary calcium excretion. Whereas if it is normal or elevated, the diagnosis would point towards primary hyperparathyroidism. With our child, the further evaluation showed a urine calcium creat ratio to be high. So we went on to proceed with the USG abdomen, which did not show any evidence of nephrocalcinosis, whereas a USG neck revealed a hypoechoic lesion inferior to thyroid, where a probable parathyroid adenoma was considered. So these are the images of the USG neck, which is showing a parathyroid adenoma on the inferior pole of the thyroid with increased vascularity also. So later on, we went on to do a nuclear scan. A sestemi B scan done later on confirmed parathyroid adenoma. So the further course was to take a surgical consult for removal of adenoma. And prior to that, the child was started on hypercalcemia. He did not require any further treatment for the hypercalcemia. He was taken up for surgery immediately. And during surgery, there was a difficulty in adenoma drop. So we got the help of the radiologist, where ultrasound was done to identify the right inferior parathyroid. It was dissected and excised in toto. In calcium levels were done 10 minutes after removal, and a fall in values were recorded. The frozen section specimen that was sent to the pathologist confirmed parathyroid tissue. Post-op, the child developed carpopedal spasms on day 2 of surgery, and it was associated with hypophosphatemia and hypomagnesemia. For this, he required high doses of IV calcium gluconate, which was again given under cardiac monitoring, along with magnesium supplementation. He also required very high doses of calcitriol to normalize the calcium levels, and with adequate calcium and phosphorus levels stabilized, he was asymptomatic and he was discharged home. So these values, they show the trend of his investigations, where a high PTH was noted at diagnosis, and during surgery, we have noticed a fall from 67 just before to 25 soon after removal, and on follow-up, the PTH was 59. The initial ionized calcium was high at 1.6, and post-op it was seen to drop. Immediately post-op, it was 1.36, whereas subsequently we faced an issue of hypocalcemia requiring corrections. Whereas with supplements, he's now maintaining at 1.15. And his vitamin D levels were initially very low at 11, and vitamin D is also being supplemented. The phosphate level have dropped from thousands to 697 right now. And there was all the phosphate levels and magnesium levels have also stabilized. And another important clinching point is urine calcium creat ratio, which was high at 0.6, has come down to 0.03. He was also advised a genetic analysis in early onset of hyperparathyroidism to rule out Men's syndrome, but his clinical exome was negative for any pathogenic mutations. So genetic testing, it is usually advised where family history of primary hyperparathyroidism of at least one affected first degree relative is present, or when it occurs in a younger age group of less than 50 years, or when 2 or more adenomatous parathyroid glands are found, or there are characters of other syndromes like MEN1, MEN2, or hyperparathyroidism jaw tumor syndrome. And if at least one is yes, the genetic test is done for all candidate genes like MEN1, CDKN1B, red gene, CASR, etc. And the positive genetic test, if the child is asymptomatic, can be routinely followed up with biochemical and radiological screenings. And if not, and if the tests are negative, there is it indicates a high probability of sporadic primary hyperparathyroidism. So the take-home messages would be to reconsider an alternate diagnosis other than nutritional rickets in the presence of a high calcium and low phosphorus in children who are resistant to initial treatment. PTH levels and ionized calcium levels should be done as a part of metabolic bone profile, and to treat and rule out secondary hyperparathyroidism causes. and to stress on the role of urinary calcium excretion in differentiating the various causes of hypercalcemia, especially primary hyperparathyroidism and familial hypocalciuric hypercalciuria. Thank you.
Thank you, Dr. Ashwini, for a very well presented case with all points for discussions also. And I think I could see that for the initial part of discussion, you were focusing on why a clinician should have suspected this not to be rickets from the start. And I think one of our colleagues, Dr. Santosh, shares similar experience and probably similar experience from my own cases where these patients are often neglectedly treated with high doses of vitamin D and calcium repeatedly. Sadly, this one also underwent a surgical procedure before actually getting to the right diagnosis. So you emphasized on the importance of measuring PTH, and any news that, sorry, we have a comment from Dr. Khadgawat, sir. Yes, sir. First.
So, hello, Ashma, I'm audible?
Yes, sir. Yes, sir. Yes, sir. Please go on.
So this hungry bone syndrome, we were seeing quite a lot not in pediatric, but in adult population. And on evaluation of our data, and as also reported by the other series, that vitamin D status of subject at the time of surgery is important. So as soon as these are diagnosed, we have started replacing them vitamin D. So at least for 4 to 6 weeks, their vitamin D levels are good before going into the surgery. And by that simple parameter, we have reduced incidence of hungry bone syndrome in most of our case of, but this is experience from adult population. Similar should be there in pediatric. Like in this case, even post-op vitamin D levels were 12 nanogram per ml. So I believe if we could have started much before vitamin D supplementation, so there might be reduction in the severity of hungry bone syndrome, or may not be there.
Right, sir. Thank you. I think when this patient came to them, the vitamin D was 16. And I think they straight away went ahead with a lot of investigations for finding out the cause. Thank you.
Yeah.
Yes, sir. Thank you. So, Ashwini, would you also want to emphasize how you preoperatively stabilize the hypercalcemia for this child? That can also
yes,
be discussed briefly.
For this child, mainly he required only hydration with 0.9% saline, around 2 to 3 times his usual maintenance. So with that, we were able to manage his hypercalcemia because he was not symptomatic otherwise. If at all it had been a medical emergency where he was symptomatic, other factors like loop diuretic like furosemide or bisphosphonates could have been started earlier to treat the hypercalcemia, or calcitonin or hemodialysis also could have helped.
Okay, thank you. I think just one question which I would want, if the faculty can help, the child being tested negative for men, would you want to consider an extended genome evaluation for this child, or would we just leave it as a sporadic hyperpara? Yes, sir.
Sporadic hyperpara is much commoner in comparison to the multiple endocrine neoplasia. In absence of any family history, in absence of any other biochemical support for the multiple endocrine plasia, and seeing the limited facilities available for the genetic workup, would be more interested in following up and look whether a child develop any other clinical feature of MEN or not.
Thank you, sir. Professor
Please,
yes, sir.
may I comment?
Yes, sir.
So first of all, a fascinating case, absolutely fascinating case. I just wonder whether if you go back and look at the skeletal radiographs, whether any sort of erosion suggestive of brown tumors that you often see in persistent hyperparathyroidism. The reason I ask is that I've seen one girl who I had to go and see in Leeds, nearby city, who really had profound lifelong vitamin D deficiency, but then she went on to develop celiac disease. And basically had persistent secondary hyperparathyroidism and then went on to develop tertiary hyperparathyroidism. So I'm just being a devil's advocate here and wondering whether this could have been started off as a nutritional dietary calcium and vitamin D deficiency, which then progressed to tertiary hyperparathyroidism. And the key would be to look at the skeletal radiographs and see whether there are any changes of bone erosions, particularly on hand radiographs,
We haven't taken a hand radiograph initially, sir. When he presented to the orthopedic surgeons like 2 years back, the radiographs of the wrist were not taken. But when we retrospectively consulted the radiologist regarding his initial X-rays, they suggested that there could be a possibility of subperiosteal erosions in his X-rays of the knee. But it was very minor and was not very suggestive of hyperparathyroidism, but we did not have a echo of the hand.
It's just that this is not uncommon. In fact, I've got a referral from a colleague in Bangalore it's a girl who's actually with severe vitamin D deficiency developed, I don't know whether Dr. Wani is on the call or not, a femoral neck fracture. And I think it's probably gone through one of these cyst-like changes that you can get with persistent, long-standing vitamin D and calcium deficiency.
Interesting, sir. Thank you. Thank you so much. So I don't think there are any more questions in the chat box. If there are any other related questions or any comments from other faculty, otherwise, I think we can go ahead with the case with the talk by Dr. Khadgawat.
Thank you, ma'am. Thank you for the guidance.
Thank you, Ashwini, for a very well presented case, and thank you all for a good interaction. I think it is now my privilege to call upon Dr. Rajesh Khadgawat for his talk on pediatric osteoporosis. So it does not need any introduction, but has been a teacher and mentor to many, including me. He is a professor at the Department of Endocrinology at All India Institute of Medical Sciences, New Delhi, with good enough work and best paper awards outstandingly seen in his resume. So over to you, sir, for your talk. Thank you.
Thank you, Ashima, for introduction, and I'm grateful to Dr. Ahila for inviting. And ACES, I'm founding member of ACES, which was started in 1996 in Sanjay Gandhi PGI, and now we have reached to that large number of members. I am right now not at my home. I am at some other city for some other conference. So it may be possible that in between we may have some break in the presentation. So I'll try to join from phone if there is a break in the presentation. Am I audible?
Yes, sir, you are. I can hear you well.
So I'm starting our experience with the metabolic bone disease in children, a case-based approach. We have seen a couple of years back. This is a routine case. 11-year-old boy was brought by her mother with complaint that he is.
Sorry,
can you just pause? Yes, sir.
Yeah. We cannot see your screen. Sorry. Do you want me to share, sir?
So Dr. Jhalak can share the screen at her end if there's a problem at your.
So not. Are you able to share because it's showing in my computer that it's being shared?
No, but we can see your slides, sir.
Not seeing?
No, sir.
No.
Okay, can I request Jhalak to share on my behalf?
Yes, sir. I'll do that.
I'll stop sharing. Yes. And I'm switching off my video also because that will give some better connectivity. Okay, so this, yeah, can we go to next? So it's a story of 11-year-old boy was brought by her mother with a history of back pain, which is there from few months, insidious onset, progressively increasing in severity. There was no radiation. There was some relief with the rest, but again, it increases with activity, especially bending, lifting object. Although there was no other features like morning stiffness, weakness of the limb, joint pain, joint swelling. Previously used to ride bicycle for hours, but now he complains of back pain even after riding bicycle for 10 minutes. So initially parents thought that his school bag is too heavy, he is carrying a school bag, so maybe because of that. But subsequently they noticed that there is a hump in the upper part of the back, and they got worried at this stage. So they consulted their family physician, who gave some analgesic, calcium and vitamin D supplementation, thinking that could be because of vitamin D deficiency. But it didn't improve any of his complaints. So finally, family physician decided to do X-ray of the spine. So next slide, please. So this was the X-ray of the spine of this boy, and you can notice that deformed vertebra, especially in the upper part of the lower part of thoracic and upper part of the lumbar. There are multiple vertebrae showing marked deformation and what we call as vertebral fracture. Next slide. So how do we grade vertebral fracture? So this is based on the Genent semi-quantitative grading system, which is initially made for adults, but later on adopted for the reporting in pediatric age group also. So in the upper line, you are seeing the 3 normal vertebra, and then if there is difference in the size of the vertebra, whether it's an anterior, middle or posterior distance, so if this difference is more than 20 centimeter, this is considered as a fracture, which is further subdivided into 20. If difference is 20 to 25, it's considered as a grade 1. If 25 to 40, it's grade 2. And if it's more than 40% difference between anterior, middle or posterior distance of a vertebra, because it's a vertebra, we know it's like a square. If it's less than 20, this is considered as a normal variation. So this is the system which is adopted for pediatric age group, also for reporting vertebral fractures. Next slide. So this is just showing photographs of not this patient, from other patient. You can see the grade 1, grade 2 and grade 3 fractures, how they look like, especially grade 3 marked deformity of the vertebra. So these are the, even if they are asymptomatic, they are considered as vertebral fractures. Next slide. So this should not be confused with some normal anatomical changes which are happening in the vertebra, especially in the pediatric age group. Like you can see this arrow is showing the area where vertebral artery is entering inside the vertebra. So there is some anterior cortical buckling is there. This should not be confused. Similarly, there is another, next slide. Similarly, there is another anatomical abnormality, which is Schormel's nodes, which is nothing but just protrusion of the nucleus pulposus from the intervertebral disc, which also give rise to some deformity. But again, this doesn't come into the definition of fracture. So these two things should be kept in mind when we are seeing the vertebral fractures in pediatric age group. Next slide. So we went back and analyzed the distances. When this patient presented to us, at that time we didn't have software support of calculating vertebral morphometry through DEXA machine. So we went ahead and manually we have calculated the deformity. So you can see that anterior, middle and posterior, there at many places the differences was more than even 40%. So at like T7, it was difference was anterior and middle was 40%, T9 70%, T10 55, 60, 45. So there are multiple fractures. Even at the L5, there was, which is considered as one of the strongest vertebra. Even that distance was more than 20%. So it was a grade 2 vertebral fracture. So we can see that there are multiple vertebral fractures. Almost all vertebra were involved in this child's back pain. Next slide. So how do we diagnose osteoporosis in adults? In osteoporosis in adults is diagnosed based on the DEXA BMD measured by the DEXA. If T score is within 1 standard deviation, is considered as normal, but if it's between -1 to -2.5 standard deviation, considered as osteopenia, and anything more than -2 standard deviation below is osteoporosis. And if more than -2.5 and plus 1 or more fractures, which considered as established osteoporosis. So this is the adult definition of osteoporosis, but whether we can apply this definition to the pediatric age group, there are many issues with that. Next slide. So how do we define osteoporosis in children? So presence of one or more vertebral compression fractures, osteoporosis is confirmed and no further investigation is required for making diagnosis of osteoporosis. We can measure BMD, we can do investigation to find out severity. But in absence of the vertebral compression fractures, we need two parameters. There should be a history of clinically significant fracture, and this is combined with the low BMD Z scores, which should be less than -2 standard deviation. If both of these features we find in any patient, we can make a diagnosis of pediatric osteoporosis. Now issue comes, what is clinically significant fracture? So clinically significant fracture has been defined if there are 2 or more long bone fractures by the age of 10 years and 3 or more long bone fractures by the age of 19 years. And if these number of fractures are there with low BMD scores, we can make a diagnosis of pediatric osteoporosis. Next slide. There are some limitations in densitometry when we are performing in infants and young children less than 5 years. The best area to scan is lumbar spine. The other site which along with the spine is total body less head, because head is not metabolically that active, so there are hardly any changes in the head. So head portion is always removed. Forearm and femur neck, which are common in adult population, are not very useful in pediatric age group. Another important issue for interpreting is because of the short stature or growth delay. So we have to do that much correction to the bone density. So if we are doing spine, so either we have to measure aerial BMD, or we have to correct for height Z score with that. Only then we would be correctly interpreting the bone mineral density in pediatric age group. Next slide. So we went ahead and did BMD measurement for this child, and based on Caucasian database provided by Hologic, the lumbar spine BMD was -2 and whole body minus head was -2. So although our patient did not require BMD measurement for diagnosis of osteoporosis, but still we measured that. Next slide. So our case was multiple vertebral fractures. The 5 vertebra had grade 3 fractures, 5 vertebra had grade 2 fractures. It was symptomatic for fractures. BMD was less than -2 at both at spine and total body. So this confirmed the diagnosis of osteoporosis. Now we haven't seen pediatric osteoporosis before that, so we were very much worried what's the cause of starting searching literature. Next slide. So we did complete evaluation. So height was 141 centimeter with Z score of minus 0.5. Weight was 38. There was kyphosis in upper and middle thoracic region, the protuberant abdomen. He has just entered puberty, so pubertal status was 6 ml on both sides. There was no other dysmorphic features or no features suggestive of osteogenesis imperfecta. Vision was normal, hearing was normal. There were normal neurological examination. And similarly, all complete workup for metabolic bone disease, corrected calcium, phosphate, alkaline phosphatase. Since he has received a lot of vitamin D before coming to us, vitamin D levels were very good. We also look for tissue transglutaminase antibody to look for celiac disease, so that was also negative. And causes for other endocrine diseases like hypercortisolism or hyperparathyroidism, all were negative, and all parameters were in the normal range. Next slide. So if we look for causes of pediatric osteoporosis, broadly divided into two categories: primary causes, which are seen in almost less than 1% of the cases. Most of the time what we see is secondary osteoporosis, and which is secondary to the especially the leukemia, lymphoma, renal failure, post-transplantation, and especially somebody is receiving high dose of glucocorticoid or methotrexate or cyclosporin. So these are the common causes of secondary osteoporosis. Or if there is any systemic illness, any cause of malabsorption or hemolytic anemia, these are the common causes of secondary osteoporosis. However, there is a list of primary causes of osteoporosis also, like osteogenesis imperfecta being the commonest. There may be Brooks syndrome, osteoporosis, pseudoglioma syndrome, fibrous dysplasia, juvenile Paget disease has also been reported. Professor Julf has given us a clear description of hypophosphatasia, although it's rare in this age group. And if we do not find anything, then there is a category of idiopathic juvenile osteoporosis, which has been reported not in terms of bigger series, but there are reports of in form of case or case series. Next slide. So we started doing workup for the causes of osteoporosis in this child, because there was no systemic illness, there were no long bone fracture, normal sclera. We went ahead and did mutations studies for COL1A1 and A2, which were negative. There was no contractures of joint, vision and was absolutely normal. Hypertonia was not there. So we thought of like it could be possibly a case of idiopathic juvenile osteoporosis. Next slide. So this is uncommon condition affecting children and adolescent, which initiates in pre-pubertal region, with there is deficiency in the bone remodeling, so thereby reducing the quantity of the calcium bones. First symptom usually appears before puberty, and more common would be vertebral compression fractures than the metaphyseal fractures of the long bone, and they have reduced bone mineral density. A lot of people have tried to find out some genetic reason, but till now there is only one report of LRP5 mutation, which was reported in most of the cases of juvenile onset osteoporosis. Next slide. So we were very much interested in going with that. So we did LRP5 genotyping. This is electrophotogram showing that there is homozygous mutation, and the same mutation was also reported in the mother and heterozygous form in father. Next slide. Remodeling of bones in children is a known phenomena, and there is very good amount of remodeling occurs, which is quite different from the adult population, because there is a thick cartilage, thick periosteum, they have more cancellous bone, their collagen is very active, presence of growth plates, stronger ligament, and bones are very active. So even if there is deformity, that can be easily corrected because of the remodeling. So this could be a phenomena, whether we can wait for this child and remodeling may occur and may correct all these deformities. But we were not sure since he was symptomatic. So we discussed with the family whether to go for treatment or not. Next slide. Spontaneous recovery from osteoporosis is well reported in absence of any osteoporotic therapy. Pediatric skeleton being a dynamic structure with distinct capability not only to reclaim bone which is lost during transition bone health, but also to reshape vertebra which are showing deformities because of any systemic illness. This is a unique feature which is not seen in adult or with the limited capacity in adults. So in pediatric age group children, they have a large capacity of remodeling. So that was the major concern for whether to treat or not to treat. For secondary causes, it's important to remove the cause of drug which is causing osteoporosis. Spontaneous recovery is very well reported, especially in cases of glucocorticoid induced osteoporosis. Next slide. This is one of the published longitudinal follow-up of case, like you are seeing in first slide. It was before starting chemotherapy in case of acute leukemia. And once chemotherapy was started, a child also received glucocorticoids. You can see that progressively there is deformities of the vertebra appears, what we call as vertebral fractures. And once the chemotherapy was stopped, reshaping of vertebra occurred because of these remodeling features, and vertebra almost become normal even in absence of any primary treatment for osteoporosis. Next slide. However, if we see how common is these vertebral fractures, this is a prospective study of 155 children with ALL, and it was found that 16% of them, all these children had incident vertebral fractures, and out of these 16, half of them were either moderate or severe fractures, and half of them again had fractures present at the baseline. So vertebral fractures which are present at the baseline increases the odd of incident fractures in next 12 months. And it was reported that for every 1 SD reduction in the spinal BMD JAD score at baseline, there was 1.8-fold increase odds of having incident vertebral fracture for the next 12 months. So it's quite common to have these vertebral fractures, especially in leukemia. Next slide. This is another study of 600 patients of ALL who were prospectively followed for the cumulative vertebral fracture incidence, and 3 years cumulative vertebral fracture incidence was reported to be 17.8%. So almost every fifth child developed vertebral fractures on 3 years when they underwent this treatment. Mean bone mineral density at lumbar spine was lower than their healthy children, and the predictors which were like younger age, lower weight, B cell immunophenotype was associated with the lower BMD at the time of diagnosis. Next slide. So even if we think of drug therapy, what are intervention drug therapies are available, this is experience is limited most to the case series, and most of this experience of treating pediatric osteoporosis comes from our experience with the osteogenesis. For primary prevention therapy, even in osteoporosis, there is insufficient data to recommend any drug therapy. But most of the people have suggested that careful monitoring of the at-risk children, treatment of the associated condition like their vitamin D deficiency or other hormonal deficiency, or if they are overweight. So it address these issues, which is more suggestive rather than going for a primary treatment, promote physical activity, and adequate calcium and vitamin D supplementation is reported as one of the most effective treatment if they are vitamin D deficient. Next slide. And till now, bisphosphonate is the only drug which has been used for treatment. And again, our experience is based on the use of bisphosphonate in the osteogenesis imperfecta. Indications for therapy: if there are low trauma, long fractures, or symptomatic vertebral fractures, or if there are asymptomatic vertebral fracture, but they belong to grade 2 or grade 3 severity, in that case, again, can think of starting treatment. Extremity fractures at other site usually do not warrant treatment. There is a lot of debate going on whether the grade 1 fractures should be treated or not, even if they are symptomatic or asymptomatic. Still, final word is not out, and grade 1 fracture is not commonly treated with the drugs in case of primary osteoporosis. Next slide. So again, bisphosphonate therapy treatment is experience is coming from the treatment of osteogenesis imperfecta, where IV palmidronate was initially used. Then later on, this shifted to the oral alendronate and residronate were used for treatment of osteogenesis imperfecta. And over last few years, IV zoledronic has been used because of very convenient dosing pattern, which can be given once or twice in a year, and which is very cost effective, especially in our scenario where with limited health resources. Next slide. Bisphosphonate, oral bisphosphonate has been found to be very effective in increasing BMD. Like this, here you are seeing that there's almost all studies except one study, which was one for anorexia nervosa. Otherwise, all studies have clearly shown that with the use of oral bisphosphonate, there is increase in the BMD. And next slide. Not only BMD is increased, this is also effective in reducing fracture reduction. Next slide. So now, even if we decide to treat, what is the dosing and regimens of bisphosphonate which can be used, there is no consensus. However, these doses are used for treatment of osteogenesis imperfecta, especially zoledronic acid. Maximum dose is 0.1 milligram per kg per year, given in two equally divided doses. So that comes to 0.05 milligram per kg, given every 6 monthly if child is more than 2 years, and half of that dose given every 3 monthly if child is less than 2 years. Although alendronate and residronate have also been used, but not that popularly used nowadays because of wider availability of zoledronic acid and convenience of its use. Next slide. So how long we should continue this therapy? Difficult to suggest anything, especially in secondary cases. We can continue therapy till the primary cause of osteoporosis in these cases have been removed, they have been effectively treated. Or if we are continuing therapy, then we can consider treating for at least for a couple of years till they become fracture free, especially vertebral and non-vertebral fracture for 6 to 12 months, or previously fractured vertebral bodies have stabilized and undergone reshaping, or BMD Z scores appropriate for the height. So these are some guidance for continuing the duration of therapy in these cases. However, in primary osteoporosis, continuation therapy till they achieve their final height, or especially their epiphysis is completely fused, because we cannot change the primary cause of therapy, or if risk factor reappear again, we can also consider thinking of reintroduction of the osteoporotic therapy in children. Next slide. Bisphosphonate is not free from side effects, and there are concerns. Most of these concerns are again coming from our experience in the use of bisphosphonate in adults, especially osteonecrosis of jaw, atypical fatigue fractures. These are the two side effects which we are concerned. Osteonecrosis of jaw has not been reported in pediatric age group, but there are a couple of case reports where use of bisphosphonate in case of osteogenesis imperfecta has reported atypical fractures. Next slide. So these are the few reported cases where use of bisphosphonate for X-linked osteoporosis they have used for 4 years and resulted in atypical fracture. But again, these are the only couple of case reports of atypical fracture in the pediatric age group. Other side effects like febrile reactions are very much limited for first couple of days. Next slide. So coming back to our case, it was very difficult to decide whether to treat or not. So we sat with the family and discussed with them, seeing the multiple grade 3 fractures, at least in 5 vertebra with symptoms with markedly low bone density. So it's a combined decision was taken to start treatment with injection zoledronic acid with this 0.05 milligram per kg every 6 monthly IV infusion. So this was started somewhere in October 13. So total 9 doses were given along with calcium and vitamin D supplementation. So within initial 6 months, there was a marked symptomatic improvement, and these infusions were continued till the fusion of ACES. And once we know that child is achieved final height, so then it was decided to stop that IV infusion. Next slide. So then we repeated bone density after 5 years. In 2017, there was a marked improvement in the lumbar spine and whole body density and Z scores, which were -2 at that time, now have come within the normal range. So BMD wise, there was a significant improvement in this child with that. So we also did family. So we also did family screening. So when we thought that we found out that mother was homozygous for LRP5 mutation, but she didn't have fracture, we did BMD, which showed that she is severely osteopenic with T-score coming at -2.3. But no fractures, and subsequently after 2 years, once we repeated BMD, there were vertebral fractures. Explanation for that, why mother is having late fractures, maybe incomplete penetration or compound mutation or variable expression with LRP5 mutations. There is limited literature with that LRP5 mutation, so difficult to comment why she didn't have fractures. Next slide. So this is serial X-rays of this child. So starting in 2013, so when we stop therapy, you can see there is a marked reshaping of the vertebra. Fractures which shown grade 3 at the time of 2013 has either become normal or converted to the grade 1 vertebra. So in terms of symptoms, there was a marked improvement. In terms of BMD, there was marked improvement. And in terms of the vertebral reshaping, there was a marked improvement. It would be very difficult to say this could have been a natural course of disease also, could have improved in absence of treatment. Also, it's maybe possible, but difficult to comment on that because there are limited literature about treatment of idiopathic juvenile osteoporosis. And Dr. Ashima subsequently, when she was working with us, she published this case in Journal of Pediatric and Endocrine Metabolism. Next slide. So in summary, osteoporosis in children is an important issue. Most of the time, what we are seeing is secondary causes. Spontaneous recovery is well reported in once we remove the causative agent. Treatment, again, it's quite debatable out of scope of osteogenesis imperfecta. Osteogenesis imperfecta we treat without much concern, but for the other causes, difficult to comment whether it should be treated or not. If we treat, options available is bisphosphonate, IV oral have shown equal effect, but since with zoledronic acid, with convenience of treatment, with cost, it's most widely used, and we can continue therapy till the fusion of epiphysis. Side effects, apart from couple of reports of atypical femoral fracture, not much reported. So this is what wanted to present in our case-based approach of osteoporosis. I think that was the last slide.
Thank you, sir, for taking us through this interesting case and giving us all important points for management and screening for osteoporosis. We have a quick 2 questions, which I think you did answer during the session, which were related to recovery in these children with during puberty, and if they could be stopped during puberty. So I hope Dr. Ravindra's and Dr. Santosh's questions were addressed during the talk, which they were. If there is any more clarification that they would want. And I think there is one question of role of IV calcium along with IV zoledronic acid. So prevention of hypocalcemia after bisphosphonates, if you would want to address this, sir.
IV calcium, I'm not sure if they wanted to IV calcium or calcium supplementation. In this case, there was hardly a role of IV calcium. So we gave calcium 1000 milligram elemental calcium with a doses of vitamin D supplementation initially, because it was vitamin D sufficient. So we gave maintenance dose of vitamin D supplementation. Am I audible?
Yes, sir. Yes, sir.
So give vitamin D. I'm not sure what they wanted to ask by IV calcium. We have not used IV calcium, and it's not advised also to use IV calcium.
I think we just needed to monitor the calciums after an infusion, if at all. But yes, no role of IV calcium per se. Right. I think there is another question in the chat where they've asked for, if a child is obese, how would you calculate or give zoledronate?
Difficult to answer. We calculated with the present weight only.
Thank you.
Maximum dose, maximum 4.
Maximum, again, difficult to tell, because all experience is coming from the treatment of osteogenesis imperfecta, like we are using at our center also. We are treating osteogenesis imperfecta, and we are using calculating the dose of zoledronic acid from the present weight only.
And so just a continuation of the question was, when should we check for BMD after the bisphosphonate therapy? So I think whether the question was for an annual screening or whether the question was something very specific related to response of bisphosphonate that we need to check is the.
Especially in pediatric age group where there is continuously increase in the bone density, it would be better to not to check any bone mineral density before 6 months. So maybe the best time would be once in 2 years, or you can check it yearly also, since there is hardly any disadvantage of BMD. There is no radiation exposure in BMD. We can check annually, but definitely not before that.
Thank you, sir. Just a closing question from my side, which I had. For what recommendations would you suggest to screen children who are at risk for secondary osteoporosis?
Yes, it's always advisable. At least we can do a lateral X-ray of the spine to see whether there is fractures or not. Especially if possible, before going into therapy for the ALL or any systemic condition where we are planning to start treatment, which contain good amount of steroid and other drugs which are known to cause osteoporosis. In these cases, it's always better to do one X-ray, which cost is not much issue. Single X-ray, they can be done, and screening is always better in all these cases who are undergoing systemic long-term treatment.
Thank you, sir. Thank you. Thank you. Thanks a lot for the lecture and answering all the queries for our satisfaction. So over to you, Dr. Jalak and Dr. Ayla.
Thank you so much, Professor Rajesh Katkawat. Thanks for coming on from Trivandrum. And in spite of your busy schedule and difficult internet connection, we're really grateful for that. Thank you so much, sir. And thank you, Ashima, for helping Ashwini through her presentation and leading the session so well. Thank you so much. And I thank you, everyone. And now it's Zalak's
Yes.
swan song.
Thank you so much, everyone, for joining today. Our heartfelt gratitude to Professor Zulf Mughal and Professor Rajesh Khatgawat. Thank you so much, sir, for accepting our invitation and sparing your valuable time. I also thank Dr. Ashima Dabas and Dr. Akanksha Parikh for being the mentors today, for moderating the cases excellently well and taking up all the discussions so well. Also, I thank Dr. Preeti Sharma and Dr. Ashwini for putting up some wonderful cases. Thank you, Ahila ma'am. It's a lot of hard work to select the topic, emailing all the speakers. Thank you so much for doing this. I also thank RX Events team for putting up the wonderful show without any technical issues. I thank all of you, all the participants, for your time and also for the valuable inputs. The next ISPAE meeting, the 25th series, will be held on 16th of September. So please save the date, and it will be a very interesting topic. So please be there. Thank you so much. And before we leave, ma'am, can we just take a photo if everyone turns the video on?
Thank you, sir. Akanksha, thank you. Dr.
I
Preeti.
think we dropped Ashwini. Ashwini is not there.
Oh,
Dr. Preeti?
okay, that's all right. Yeah. Thank you so much, Preeti.
Thank you.
Thank you.
Thank you very much, sir. Thank you, Professor Mughal, and thank you, Professor Katkawat.
My slide.
Oh,
Thank you.
that's okay.
Good night. Good night.
Good night.
Good night.